without ado today, genitourinary cancer management in North Carolina, updates for 2023 with Dr. Tan, MD, MSHPM. And so let's jump in, find out a few things about Dr. Tan and meet him and get started. There's the full bio, but we're going to go ahead and jump right in and find out some highlights. Dr. Tan is an associate professor of urology and directs the Urologic Oncology Fellowship. He is director of the Urologic Oncology for the Department of Urology and is co-founder of Lineberger's multidisciplinary urologic oncology program at UNC. He's raised in North Carolina. He received his medical degree from the University of Michigan, where he also completed his residency in urology. He obtained advanced fellowship training in urologic oncology and health services research through the Institute of Urologic Oncology and the Robert Wood Johnson Foundation Clinical Scholars Program at it's hard not to say that UCLA. I say UNC so much, it's hard not to put that in there. And Dr. Tan specializes in the management of prostate, kidney, bladder, and testicular cancer, and he performs complex open and robotic surgeries for cancer. All right. So, Dr. Tan, thank you so much for being here. We really appreciate it. You're actually not in Chapel Hill, but in Boston, I understand.
Yeah, thanks, Tim. Excited to be here and look forward to this next hour.
As do we. And what's one thing we should know about you outside of your professional bio?
I love to eat. So if anyone has a good restaurant recommendation, please share it in the chat.
Great. All right. Thank you so much. We'll go ahead and open up with that poll everywhere question. What percent of your patients have a urologic cancer? And so you can put 0 to 25, 25 to 50, 50 to 75, or 75 to 100. And while you're thinking about that and answering that, I'll flash up our disclaimers and disclosures. And here we go. So we'll take about another 15 seconds. And so it looks like most of our listening audience is right in that 0 to 25%, but a few folks with higher percentages there as well. Any comments on that, Dr. Tan?
Oh, no, I think it's, it's interesting. I know it's a diverse group of people that join us for these seminars. So this is just really interesting useful for me to help sort of tailor the presentation. Looks like there are a few people who see a lot of patients with urologic cancers. They probably could give this talk. So excited for that.
All right. Genitourinary cancer management in North Carolina. Updates for 2023. I'll turn it over to you.
All right. Thanks, Tim. First off, I just want to thank Tim and Lineberger Comprehensive Cancer Center for giving me this opportunity to share some updates in our field in urologic oncology. It's a quite dynamic field. In fact, there's a big meeting happening in Europe right now where things are changing as we speak. Unfortunately, that information couldn't make it in before the slides were due. But it's great. Every year or two, we see a sort of a groundbreaking change. And hopefully I can give you a bit of flavor for that. So just to my individual disclosures, I have funding support for research from Lineberger Comprehensive Cancer Center, the American Cancer Society, and the Department of Defense, as well as a little bit from the NIH, but no conflicts of interest to disclose here. And just to start at a very, very high level, based on the poll, a lot of folks who are joining in don't necessarily take care or see or have patients with a urologic cancer, but urologic cancer actually is quite common, and you'd be surprised in how much this kind of pervades into the community. So in terms of just cancer incidence, prostate, bladder, and kidney cancer are 3 of the top 10 most common solid organ cancers in the United States. Prostate cancer is the most common cancer in men and the second most common overall. Bladder cancer is the 5th most common cancer. A lot of people actually don't realize that bladder cancer is actually in the top 5, and kidney cancer is rising and is right there at number 6. If you think about urologic cancers in terms of share of cancer survivors in the United States, about 1 in 4 cancer survivors in the United States have a urologic cancer. And so, more than likely, even if you may not be providing direct care of someone with urologic cancer, there's a good chance that someone in your practice or someone that you're taking care of on the floor or someone you're taking care of in the clinic or a family member may be affected by urologic cancers. The other thing to note is that testicular cancer, which is the last cancer we'll sort of touch on today, is actually the most common cancer in young adult men and amongst the most common in young adults as well. And so that is something that is also surprisingly common to folks. So today, the main objective is to provide some highlights in prostate cancer, bladder cancer, kidney cancer, and testis cancer. I'm going to mainly do so from the perspective of a urologist, a urologic cancer surgeon. There's plenty of updates, looking back at some of the GU management updates that have been provided in previous years. Oftentimes they've been provided by a medical oncologist. And so I think there has been more of that information that's been out there. And so I will provide some of those updates, but through the lens of someone that's really primarily diagnosing patients and treating them with surgery. So the first poll question is, what cancer has the largest racial disparity for mortality in North Carolina? All right. Well, it looks like we have a pretty smart room in here. So about 63% pick prostate cancer, and that's true. Prostate cancer actually is the cancer with the largest disparity in terms of mortality in the state of North Carolina. And I think it's really interesting to think about that in the context of what I'm just going to touch about today. I'll start off by saying, though, that we have a whole dedicated research to practice seminar coming up in a few weeks that will be presented by my partner, Dr. Bierland, who's quite the dynamic speaker. I encourage you to join in for that seminar. Prostate cancer gets its whole dedicated session because there's so much active going on. But the one thing that I wanted to highlight is the question of prostate cancer sort of epidemiology as well as prostate cancer screening. As probably many folks may be aware of, prostate cancer screening has been a process in evolution. It used to be done more widespread back in the early 2000s. This sort of corresponds in this figure here, which on the left-hand side of the screen looks at the incidence of prostate cancer diagnosis, which is this brown bar here in men at the top. You can see shortly after the discovery of prostate-specific antigen in the early 1990s, there was a real spike in prostate cancer diagnosis, and this settled down after a little bit. And then in 2008, the U.S. Preventive Task Force recommended against prostate cancer screening for elderly patients over the age of 75, and then gave it a D recommendation in about 2012, saying that the harms generally outweigh the benefits. And this is sort of based on some screening trial data that from Europe did show a small benefit, but the major one for the United States really didn't show any major benefits, but there was a lot of issues with that study. And then since that time, we saw a pretty significant decrease in the use of PSA testing. What we have seen since then has sort of been a bit of a natural experiment. When we stopped doing the PSA testing as much, we then started to see an increase in prostate cancer diagnosis. The incidence of prostate cancer diagnosis has been actually increasing 3% per year. And what's perhaps more worrisome is that we're seeing more men being diagnosed with locally advanced and metastatic prostate cancer. And so the incidence of advanced disease has actually been increasing at a higher rate of 4.5% since 2014. And then what we notice here in the right-hand figure, when we look at sort of cancer mortality per population in men, whereas over the past, essentially since 1990, since the inception of PSA, this steady decline in prostate cancer deaths, we're actually starting to see it level off and over the last few years. And this corresponds roughly with the change in prostate cancer screening recommendations. In North Carolina, this is perhaps even more magnified. In North Carolina, about 20% of the state, are Black. Here in the United States as a whole, the difference in mortality is about a 2-fold difference. In North Carolina, it's a 2.4-fold difference. And so we're seeing more patients in North Carolina, more Black men, diagnosed with prostate cancer, and more Black men dying from prostate cancer here. And so this represents a really significant cancer disparity that we are hoping that we can address in the short term. One of the big reasons for not doing as much PSA screening was this concern about overtreatment and harms from that treatment. And certainly prostate cancer surgery and prostate cancer radiation have morbidity associated with it. This includes incontinence, urinary leakage, erectile dysfunction, as well as side effects from the radiation treatment. And that was one of the major motivating factors for the recommendation that was given back in 2012. Well, we've seen since then, and as illustrated in this figure here, there has been a real strong embrace, and this represents a real shift in the seas of management approaches for patients with low-risk prostate cancer. These are patients who are diagnosed with prostate cancer that's unlikely to cause them any sort of harm. Really, there's been this big push to watch those patients with serial PSAs and biopsies as opposed to proceeding with treatment. This started around 20%. This blue line on the left-hand side is sort of national data from research that one of my PhD students and one of my urologic oncology fellows were doing, and they found that in 2008, just a little over 25% of men were getting active surveillance, and this increased to over 60% by 2017. In the state of Michigan, which UNC were part of a quality collaborative with urology practices in Michigan. And so we have sort of access to this data. Their rate of active surveillance from 2012 increased from about 50% to over 90% in 2021. And at UNC, our individual in practice active surveillance rate is about 95%. So we've really changed how we approach patients with prostate cancer. In doing so, we are reducing the harm and overtreatment of patients with prostate cancer. And so that changes the calculus of whether screening may be potentially beneficial or not. And then we're sort of seeing this move amongst different organizational bodies in the United States. The American Cancer Society has really sort of had a call to arms for patients at risk for prostate cancer, especially for Black men and those with a family history who may be at elevated risk. They actually recommend that initial PSA testing be considered or at least discussed with patients around 40 or 45 for those patients at risk. This is very similar to the American Urological Association, where we recommend a initial discussion about PSA screening around 40 to 45 for those who are at risk and 45 to 50 for an average risk man. And then U.S. Preventive Task Force, which, as I sort of alluded to, kind of was the impetus for a lot of this change. They're actually right now, you're starting to see that they are evolving in the recommendations. As I mentioned, in 2012, they initially recommended against screening. In 2018, they changed it to a grade C, still highlighting the harms that they saw with it. And they're right now revising that guideline, and it'll be interesting to see where they fall on that. In addition to the embrace of active surveillance for patients with prostate cancer, another thing that is more nuanced that we're starting to see in PSA screening for prostate cancer is that there is a movement away from the annual PSA testing. So for patients who have a normal PSA, they probably don't need a PSA every year. The Gothenburg trial in Europe had a 2-year cadence. You can see in the AUA guidelines that they suggest every 2 to 4 years for patients at risk. And so that's something that we'll continue to see some changes and recommendations from different organizational bodies. And I don't want to steal Dr. Bierland's thunder, so I'll leave most of the rest to him, but there's definitely new advances with respect to types of treatments, including focal therapy, new imaging studies, including the PSMA PET-CT. And so, please join in for his presentation in a few weeks. The next section is bladder cancer. And so bladder cancer, I mentioned, is the 5th most common cancer in the United States. It's typically associated with smoking. I think people often will think about smoking associated with lung cancer, but bladder cancer is also a disease that smoking is a major driver of. We broadly think of bladder cancer in terms of 2 types. There's the muscle invasive type that is more aggressive and often is treated with surgery and radiation and chemo. And there's actually non-muscle invasive bladder cancer, which actually makes up the majority of bladder cancer. This is a different sort of beast. This is a disease that is more chronic in nature, that requires patients to be surveyed, and treatments often start with therapies that are more local to the bladder, like giving different medication therapies and putting it into the bladder. One of the mainstays of treatment, and this is one that most patients will receive as the sort of initial treatment, is BCG. BCG is an attenuated tuberculosis vaccine. It was first reported in 1976, and the mechanism is a little bit unclear, but it's thought to elicit an immune response as well as a local response as well in the bladder. About 70 to 80% of patients will have an initial response. It's recommended for this subgroup of patients with non-muscle invasive bladder cancer that have more aggressive features. And it has been the first-line treatment for patients over the last few decades. There are side effects associated with it, like lower urinary tract symptoms, fevers. There's a rare thing that can happen that is something that can be quite serious called disseminated BCG sepsis. These patients present looking like a full-fledged acute tuberculosis attack and can be quite sick, require often ICU care, and require triple drug therapy for tuberculosis, essentially. Where the challenge lies with BCG are sort of twofold, actually. One is a sort of effectiveness issue, and the other is a supply chain logistics issue. There used to be multiple makers of BCG, but that's been reduced to one, and so there's been multiple challenges where practices and patients can't get access to BCG. And then, although 70 to 80% of patients respond to BCG initially, about 40% do develop long-term failures. And so, what do you do essentially next for those patients? And so, there's been a variety of different investigations in this space to figure out what the options are. The one that has been sort of around for a while as a salvage option has been intravesical gemcitabine and docetaxel. So this is a therapy where we instill gemcitabine diluted into either sterile water or normal saline. We instill into the bladder. We let it dwell for about 60 minutes to 90 minutes, and then drain it out, and then do the same with docetaxel. What came out recently is a retrospective study, so the evidence is not the most robust, but in this study, because we have had these periods where BCG, you just couldn't access it, the University of Iowa compared this gemcitabine docetaxel combination with BCG. And then what you can see in the survival curve here is that it looks like patients who got the gemcitabine docetaxel actually had a higher response and had a lower rate of recurrence at 1 year. Their recurrence-free survival at 1 year was 81% compared to 67%, and over 90% of patients on this alternative regimen were free of progression or needing to have their bladder removed at 2 years. There's, inherent weaknesses to the data. It's retrospective. There might be biases. There's also this time delay. patients who, there's been other studies that show that in more recent years, those who are getting BCG actually seem to have a higher response, almost upwards of 80% as opposed to around 70% in this historical data. But this is really exciting because Gem-Doxy is a regimen that may potentially be more widely available to folks. Because of this, there is a now large multi-center SWOG trial that's being conducted that's going to test to see which one is better in terms of cancer effectiveness. In the salvage setting, so for patients who failed BCG, as I mentioned, about 40% of patients will fail BCG, and oftentimes we are looking at different treatment options because patients want something other than having their bladder removed. We see very promising results with gemcitabine docetaxel. Just to lay this sort of groundwork a bit, other than this regimen, the existing salvage therapies, 5 years ago, had response rates in the order of like 20 to 30%. The FDA actually set a threshold of complete response of 30% for approval of medication. So the bar was pretty low, and I think that's reflective of how ineffective a lot of the salvage treatments have been. The one standout from it is this gemcitabine docetaxel combination. This again is data from the same Iowa group. What they show is that their initial response rate with this regimen, which is given once a week for 6 weeks, then a monthly maintenance regimen to sort of maintain the effectiveness of the treatment. They found that 75% of patients had initial response. About 40 to 50+% had no recurrences at 1 to 2 years. And again, the majority of patients were able to avoid progression to muscle-invasive disease or need to have their bladder removed. So just keep those numbers in mind: 75% initial response, 40 to 50% recurrence-free survival at 1 to 2 years, because that will be a good benchmark as we consider other new therapies that have been approved. So one therapy that was really the newest approval that happened a couple of years ago is pembrolizumab, or Keytruda is the commercial name. This is used in many different cancers, so some of you may have familiarity with it. It's given as an infusion therapy every 3 weeks. And what they found is in patients with non-muscle invasive bladder cancer, specifically carcinoma in situ, who were unresponsive to BCG, when they gave this therapy, 41% of patients at 3 months had a response to it, which again is above that FDA threshold. And so this ultimately was approved as a salvage therapy for patients with non-muscle invasive bladder cancer. Unfortunately, kind of as you follow it along, you start to perhaps get a little bit less enthusiasm because the 2-year complete response rate drops down to about 14%, which is lower than what I just shared with respect to gemcitabine and docetaxel. Another new medication that just got FDA approval about 10 months ago has been Adstiladrin. This is an attenuated adenoviral gene-based gene therapy. And so essentially they link this adenovirus with interferon, which actually is a type of immunotherapy, and essentially administered into the bladder. And the bladder uptakes this virus and it delivers the interferon, and this elicits an immune response. There is some nice features of this therapy. We actually had this trial over at UNC, and it was actually very easy to do, because whereas patients with these alternative regimens or BCG have to come in weekly for 6 weeks and then come in for these maintenance therapies, which either can be once a month or 3 treatments or 3 weekly treatments every 3 months for BCG. Adstiladrin is given once every 3 months. So it's like 4 treatments over the course of a year. Patients can have some side effects related to local urinary problems, some dysuria, pyrexia, fever, chills. But overall, it's been pretty well tolerated. The initial complete response rate is 57%, with a complete response rate of 1 year of 46%. So looks, to be potentially higher than Keytruda or pembrolizumab, perhaps not quite as good as the Gem-Doxy combination. And then the other new kid on the block is IL-15 superagonist. This is and again, a cytokine that uptakes or sort of upregulates natural killer cells and T cells. We've had these trials here at UNC as well. The results of those trials were just released last year. And what we see is that in patients who have the highest risk group of non-muscle invasive bladder cancer, when you give this therapy plus BCG, about 71% of patients developed a complete response, with over 50% having a complete response at 2 years, fairly comparable to the gem-doxy combination. We don't see quite as robust results when we look at patients without, not quite in that highest tier of non-muscle invasive bladder cancer. And they also had an arm where they just gave this therapy alone without BCG. I should also say that this therapy is given intravesically too, so it's again given into the bladder. And so it looks like it's best when given with BCG. Unfortunately, it didn't get approved this first go around, but I think those in the field are expecting that this is going to get approved in the near future. So just to kind of recap the sequence of sort of non-muscle invasive bladder cancer, and those who are what we consider high risk, who have like some high risk features in terms of like size, carcinoma in situ, pathological features. We start with induction BCG and maintenance therapy for those who failed that. The recommendations are to do a second induction course in the future, depending on how the approvals go and how some of the subsequent studies go. It would be not far-fetched to imagine that this BCG is given now with IL-15. Generally in my practice now, though, if patients fail BCG ×2, we put them on a clinical trial. And then we move on to gem-doxy combination therapy, and then probably we'll then move them to Adstiladrin once we have it here at UNC, which we anticipate having in the first quarter of 2024. The last thing I would just say is that for these patients, radical cystectomy is a consideration. There is, some observational data that suggests that patients who have non-muscle invasive bladder cancer to start and then progress through these therapies to muscle invasive bladder cancer actually do worse than those who initially present with muscle invasive bladder cancer. Part of that may be due to delays in care or access. Others may point to the biology of the underlying cancer. So that is non-muscle invasive bladder cancer. Next, I'll start talking about muscle invasive bladder cancer. So muscle invasive bladder cancer, as I mentioned, accounts for about a third of bladder cancer diagnosis up front. I often will counsel patients that this is a very serious disease. Without any aggressive treatment, most patients will die within 1 to 2 years. And most of these patients who, don't get treatment will, have and experience a lot of significant symptoms, such as blood in urine or pain. And so this is something that really can be a difficult way to succumb in the long term. The historical standard has been cystectomy for surgery plus chemotherapy beforehand. And that has been, I think, the historical standard for now well over a decade. The sort of newest thing that's come out with cystectomy, the surgery itself, has really been about robotic versus open cystectomy. There was the previous Razor trial that we actually had at UNC several years ago, which showed that there really wasn't much differences between robotic versus open cystectomy in terms of short-term outcomes. This is a more recent trial that just came out last year. This was conducted in the UK. And it was about 150 patients in each arm. And what they actually compared was patients who got both the cystectomy and the urinary diversion, or the part of the surgery where we figure out how to reroute the urine, all of it robotically, compared to a completely open approach. Probably in the United States, the still predominant approach for those doing robotic surgery is to still do that urinary diversion part open. And what they found is that there was a modest difference between the two. If you look at the first 90 days after surgery, those who had a robotic approach had 2 less days, so 8 days in the hospital system versus 10. There was also some small difference with respect to wound complications and blood clot complications. But really, there wasn't much difference elsewhere. was about a 2% mortality rate. There was a difference in readmission rates, but pretty much almost everything else was pretty similar between the two. There was no difference in survival, no difference in recurrence in the bladder cancer. I think perhaps one of the most striking things about this study was the detailed quality of life and functional status data they collected. You can see that here on the right of the screen. And this really nicely shows sort of the experience for patients who have surgery in terms of a decrease in quality of life, reduced functional status or increased disability, reduction in steps and getting up. And this really details nicely the trajectory that most patients experience. It takes about 12 weeks for patients who have a cystectomy to rebound, but on average, patients do recover from this surgery nicely. And it also suggests that mortality rate may not be as high as it was, a decade ago. There were studies that came out using population-based data that estimated a mortality rate of like 7 to 10%. That was in an older population than what's in this study, where the average age was around 69. But here, the mortality rate was 2%. The other thing to highlight with respect to local treatment for muscle-invasive bladder cancer is the emergence of trimodal therapy as an option. Most guidelines now include trimodal therapy as a legitimate option for patients with muscle-invasive bladder cancer. Trimodal therapy involves 3 different types of treatment for patients. They get a TURBT, or scraping of the bladder, as much as possible. They get chemotherapy as a prior towards radiation therapy. And so trimodal therapy refers to all 3. This is a retrospective study that was done and published recently. This came from 3 high volume trimodal therapy institutions and in a sort of well-selected patient. So these were patients who had a solitary mass less than 7 centimeters, no CIS, no hydronephrosis, which is an indicator of more advanced disease. You see when you use different statistical methods that there doesn't appear to be any difference in disease-free survival or cancer-specific survival between that and radical cystectomy. The benefits of trimodal therapy is that patients can keep their bladder. There's been some studies that suggest perhaps some better quality of life with that approach. But there are some inherent challenges to a trimodal therapy. It involves care coordination. Patients will need to get ongoing cystoscopy for their surveillance. And about 15 to 25% of patients will ultimately recur and need to have their bladder removed. And that could be a more difficult surgery. It's not impossible to do, but there is a mixed data about whether there's more side effects or complications associated with it. The next thing I wanted to touch upon is just sort of some updates to the use of neoadjuvant therapy for muscle-invasive bladder cancer. As I mentioned before, for muscle-invasive bladder cancer, the historical standard had been neoadjuvant chemotherapy followed by surgery. And this is based on studies that were done, sort of like 2 decades ago plus, that show that there is about a 5 to 10% survival benefit for patients getting chemotherapy prior to their cystectomy. And one of the things that they drill down on is this concept of complete response and downstaging. When you look at sort of post hoc analysis, we see that patients who really responded very nicely to chemotherapy and almost had no cancer left or very little cancer left, those patients did exceedingly well afterwards, within a survival of something as high as 80+%. If you had a complete response to chemotherapy. We actually see pretty similar things in historical cystectomy studies, where if after their TURBT resection, they were downstaged. And we also see this from national population-based data for those who were downstage from their initial stage down after chemo to something lower. Those patients do well and actually have a pretty solid prognosis. And so this is important as we think about how can we fine tune and improve the neoadjuvant therapy options for patients with bladder cancer. This is one of the newer studies that's come out, the VESPER study. This is involved 500 patients, about 400 of which had neoadjuvant chemotherapy, and they compared dose-dense MVAC versus gemcitabine cisplatin combination. And they for the dose-dense MVAC arm, it was 6 cycles. For the gemcitabine cisplatin arm, it was 4 cycles. And what they found was that there was a higher rate of complete response, 42 versus 36%, a higher rate of partial response, 77 versus 63. And it looks to be an improvement in at least 3-year progression-free survival between the two. And so this has people, starting to think that there might be a better benefit from this alternative regimen of dose-dense MVAC over gemcitabine cisplatin, which has become the de facto sort of standard just because it tends to be a better tolerated option. Actually, the original studies, they often were those that were studying MVAC as a chemotherapy regimen. What's the interesting thing about this study is that it's almost like an apple to orange comparison. You're comparing 6 cycles of 1 versus 4 cycles of 4. What we're starting to sort of observe in the sort of across the state is that there's been this question of, do you do 4 cycles of gemcitabine cisplatin, which has been for the most part the standard, versus 6 cycles. I think that's extrapolated from some studies in metastatic bladder cancer that have looked at and done 6 cycles for gemcitabine cisplatin and show that those results can be pretty good. I think the one thing that I would say is that even though the perception is that gemcitabine cisplatin is better tolerated than dose-dense MVAC, when you actually look at 6 cycles being given, you start to reduce the amount of patients that can actually make it all the way through. And the different types of chemotherapy or conventional chemotherapy is just one part of it. There's a bunch of different studies that are being conducted now looking at chemotherapy plus immunotherapy or checkpoint inhibitors specifically. There's also been tons of studies that look at immunotherapy for patients who are ineligible for cisplatin-based chemotherapy. What's interesting is that you see that the complete response rate appears to be fairly comparable across the different studies. Now, these are not, head-to-head trials, and these are, it's always difficult to compare different trials because the eligibility criteria can be different. But we do see sort of this consistent 1/3 of people who get a complete response. If you include partial responses in that, patients who are getting chemotherapy plus immunotherapy, may have a little bit more, and that'll be something to keep an eye out for. The other thing that's really interesting to keep an eye out for is enfortumab vedotin, which is a anti-Nectin-4, it's the cell surface protein that can be given in combination with a checkpoint inhibitor, like Keytruda. Just like yesterday, they presented the results of a randomized control trial looking at pembrolizumab or Keytruda with enfortumab. And this appeared to provide a very significant benefit for patients with metastatic bladder cancer. And so it'll be very interesting to see how this moves into the perioperative neoadjuvant space. And then this, the goal of getting people with a complete response and knowing that they do well is really leading to this push to try to figure out, are there better ways that we can preserve people's bladders so we don't have to do the surgery and remove it? And so this is a study that is just opened here at UNC, Retain 2. This is a interesting study where there involves some molecular biomarker component. For those who have a specific gene alteration, they'll get a combination of nivolumab and MVAC chemotherapy, and then they will be assessed to see whether they have a complete response or not. And depending on the level of response, they may have surgery or radiation or observation. And so this is going to be a really informative trial on how we can better personalize bladder cancer care and whether we can more effectively spare those who may not want their bladder removed. I think one of the inherent challenges that we have is we don't have a great way of really determining a complete response short of removing the bladder. There's been a study that came out of Fox Chase that looked at whether just looking at the bladder and even doing random biopsies is effective. They found that of those who looked negative and had a negative biopsy, about half of them actually still had invasive bladder cancer, which is a bit concerned if you're trying to salvage it based on those sort of intermediate findings. And the last thing I'll talk about with bladder cancer is the new emerging approval of immunotherapy in the adjuvant setting. So in this study, Checkmate 274, they looked at using nivolumab for up to 1 year. This is an immunotherapy similar to Keytruda that's given every 2 weeks as an IV infusion. This was in patients who were deemed high risk, so those who had neoadjuvant chemotherapy and still had muscle invasive disease for node positive disease, or those who didn't get it who had locally advanced disease. And what they found is that those who got nivolumab had a reduced progression, disease-free survival. And so here at UNC, what we've been doing is that for patients who are at high risk after they get neoadjuvant chemotherapy, we have been sending them over to our medical oncology colleagues for consideration of nivolumab maintenance, nivolumab adjuvant therapy. This is not to say that everything in the immunotherapy space is perfect. There was a similar study in Vigor that was done around the same time. This showed no benefit between giving it as an adjuvant therapy versus not. And it's not quite clear why this is the case. Actually, the cohorts on the surface appear fairly similar. There might be perhaps more discontinuations or dose interruptions with the IMvigor study that might potentially account for the lack of a significant difference here. And the last thing I just wanted to touch on in this section is the role of chemotherapy for upper tract urothelial cancer. So, we've been talking mostly about bladder cancer. Urothelial cancer of the ureters or the renal pelvis, which is sort of what I would always refer to as the plumbing of the urinary system, is a very close cousin for bladder cancer, and but it affects less patients, and so it's hard to have studies that tell us what is the best option for them. We often will extrapolate from the bladder cancer studies on what to do, but this was a randomized controlled trial that came out recently over the last couple of years called the POUT study. This was a study of about 130 people in each arm, looking at the use of adjuvant gemcitabine cisplatin in patients with upper tract urothelial carcinoma. What they found is that there is a pretty sizable 3-year progression-free survival benefit for those who, and disease-free survival benefit for those who got the gemcitabine cisplatin. And this appears to be, as you can see here in the subgroup analysis, very concentrated in those who have gemcitabine and cisplatin specifically, as opposed to carboplatin. For those who may not be aware, whether you can get cisplatin versus carboplatin is really dependent on how your kidney function is. And when you're doing surgery to remove a kidney with upper tract urothelial carcinoma, you're, as a result, reducing kidney function. So the idea is that if we do therapy in the neoadjuvant setting, we can perhaps give people the preferred regimen. So this is a process of evolution of trying to figure out who those patients are who are most likely to benefit. But at UNC, increasingly for those with high-grade urothelial carcinoma of the upper tract, we are giving them often gemcitabine cisplatin. For those who are having complications of that therapy, though, we often will move quickly to surgery. So that brings me to kidney cancer. And that also brings us to our next poll question. So for patients who have a small renal mass or a tumor less than 3 or 4 centimeters in size, what % of those are benign cancers? Or benign, not benign cancers, but benign lesions. So just in your time, we'll move forward. But it looks like the poll was 30 to 40%. I think, a lot of sort of the systematic reviews would usually sort of sell on 20 to 30% as being sort of the rate of benign lesions for a renal mass, sort of suspicious for kidney cancer on the CT scan, but certainly 30 to 40% is pretty close to that. So, kidney cancer, as I mentioned, is the sixth most common cancer in the United States. Most of those who are diagnosed in the United States actually are diagnosed with a stage 1 or clinical T1 tumor. These are less than 7 centimeter in size, and most of those are less than 4 centimeter in size. And one of the interesting challenges of that is that there's about 20 to 30% of patients who have these masses identified on scan. Oftentimes it's completely asymptomatic and it's not cancer. And the other sort of complicating factor is that these patients now have increasing options for what to do. Those options may include surgical removal, ablation with sort of cryotherapy or radio frequency ablation, observation. There are also some newer ones on the precipice, like radiation therapy that can be used for patients with small renal masses. And so our team at UNC has been looking at what the decision-making experience has been for these folks, and also are there better ways to select out who would benefit from treatment versus who may not have, or for those whose treatment may not be as critical. So this is a study from our team here. And what's interesting is that, the overall decisional conflict or uncertainty that patients experience on average is not that high for small renal masses. I think this is based on qualitative follow-up studies that we have done, that most patients, their sort of bias is to want to have things that could be cancer removed, and that's predominant treatment. So most patients don't have an issue with that. But there is at least half of patients who do have some uncertainty about their decision at some point during this initial experience. And so there's definitely opportunity here to make this better. And I covered this here. The other thing that's worth noting is that, we've been looking at the genomic signatures here at UNC to see if the biopsy signature matches up with the specimen signature. What we found is that there's a lot of heterogeneity in what the genomic signature is in the actual specimen. And it's captured to some degree by biopsy, but not completely. So there's still work to be done here in terms of creating an additional test that we can use that can further risk stratify patients. In the interim, there are new imaging and diagnostic sort of tests that we can consider to give us more information. One would be, one would be renal mass biopsy, as I talked about. This is generally an outpatient procedure that can be done. It's highly accurate in terms of telling whether that mass is cancer or not, and it's about 90% accurate overall. There's a new scan that's been out for a few years now called the Sestamibi scan. This actually is a nuclear medicine test that looks at whether a tumor is a specific type of benign tumor, the most common one. It's about 78% accurate, but relatively cheap and inexpensive to do. And then finally, there's a new tracer that just has been, the preliminary data has just been released. The full publication is not available, but this is a tracer that tags CA9, which is upregulated in hypoxia and the specific gene mutations that are associated with kidney cancer. And this is about 86% accurate. We are expecting that this is going to come to market probably in the next year or so. One of the challenges, though, with this new tracer is that it needs to be administered 5 days prior to the actual scan. So patients have to make 2 visits for that test. The other big sort of change in the kidney cancer space is just the combination therapies and systemic therapies that have become available. Over the last 2 decades, we've seen targeted kinase inhibitors and now immunotherapy and now combination therapies. And this has really changed the landscape of kidney cancer. In the sort of prior 1 to 2 decades, for patients who are presenting with stage 4 kidney cancer, we would, in patients who could tolerate surgery, do what we call a cytoreductive nephrectomy. And what's interesting, this is like one of the very few cancers where you would take someone with stage 4 cancer who had disease elsewhere and still take them to surgery for local treatment. This is based on data that showed a survival advantage for doing that, followed by immunotherapy. There's been a couple of more recent studies that have really put that into question. This is the SURTIME study, which compared doing surgery followed by targeted kinase inhibitor therapy versus those who got targeted kinase inhibitor therapy first, followed by surgery. And actually, those who got surgery first did worse. And this was followed by the Carmina trial, which really has been practice changing. This is a randomized control trial of 450 patients that compared doing surgery followed by sunitinib versus sunitinib alone, sunitinib being one of the targeted kinase inhibitors. And what they found is that there was really no difference in terms of cancer-specific survival and overall survival, and it was designed as a non-inferiority study. And if anything, there looks like there might be a slight advantage for those who got just the systemic therapy only, as opposed to those who got surgery and systemic therapy. So it runs very much counter to the prior research. As you dig in more to it, though, there's been, a fair amount of critiques of the study. It was poor accrual. They revised the study design multiple times and ultimately only got 450 of like over 1,000, which was the original accrual target. And then when you did based on qualitative work that the team had reported out, there was a lot of patients who presented with metastatic disease who would be eligible for the study, but weren't enrolled because the providers or the patients had a strong thought about what they wanted to get done. In a post hoc analysis, they found that patients in the systemic therapy only who actually got surgery afterwards too, because they had, likely a good response, those patients actually did the best with a median survival of almost 4 years. That's 4 times sort of the historical norm. And so this continues to be an evolving space of what the role for surgery in the metastatic kidney cancer setting is. But certainly we're doing probably less upfront surgery and starting patients on systemic therapy and seeing how they do. These type of results really, leads to the next question of if you can improve and help patients with metastatic kidney cancer with systemic therapy, can you also improve and help patients with systemic therapy for those that are not metastatic? And so, these are 3 recent cases where we've given systemic therapy for patients with very advanced kidney cancer. As you can tell by the pictures here, the top picture is sort of their baseline, and the second below picture is their response. For patients here, in this one on the left side, almost unresectable, and you can see a much smaller mass in the kidney on the left side. Here you can see this big, bulky IVC in the liver, and you can see significant decrease in size there. And then on the one case on the right, this person you can see in the middle had a tumor thrombus going all the way up to the heart, and then with systemic therapy has shrunk all the way down to just inside the IVC. And so for all these patients, we were able to do surgery and do a more feasible surgery and safer surgery for them because of their response. This is definitely not standard of care as of yet. There's been multiple studies that have been ongoing to look at the role of neoadjuvant therapy. The ones that are out there, there's one big one that was actually terminated early because it didn't seem to show any benefit with respect to recurrence-free survival. And there's another one that has shown, a relatively modest response of only about 30% with tumor shrinkage. But this is something that, will be something we'll be keeping an eye out for moving forward. And then just to touch on briefly, there are 2 FDA-approved agents for adjuvant therapy. The STRAC trial looked at sunitinib as an adjuvant therapy given for patients with high-risk kidney cancer, and Keynote 564 was looking at pembrolizumab, again, as adjuvant therapy for those with localized kidney cancer, but potentially at risk for recurrence. These both showed a progression-free survival benefit. What's interesting to note is that there's been many, many studies that did not show a benefit. So these are 2 that are out there. This, I think, ultimately comes down to a shared decision-making between our medical oncologists and our patients to decide whether they want to undergo these treatments versus not. So I know I'm running a little bit over, and so I'll just test on testis cancer very quickly. So testis cancer, as I mentioned before, we'll skip this just in interest of time, but testis cancer is the most common cancer in young men. It's actually a success story in cancer where 90 to 95% of patients are cured of their cancer. That's like one of the only ones that you can say like with that certainty that you're going to do okay with this. But it has a lot of morbidity associated with it. There's a 2 times fold greater risk of cardiac toxicity and secondary secondary cancers, and about a third of patients with testis cancer actually have significant mental health effects from their disease. In recent years, we've had guidelines now to sort of inform how we manage these patients. Some of the basic principles that have been emphasized is really having a better appreciation for the survivorship issues in terms of fertility, in terms of testosterone levels. One of the new things that has come out recently is this idea of, for very small testis masses, do we need to remove the whole testicle? That used to be sort of the general rule, is that you saw a lesion is suspicious for testis cancer, you took out the whole testicle. Now for lesions less than 2 centimeters, there's been some small studies that show that a good chunk of these are actually not cancer. And for patients, if they're informed of the potential risk, you could consider doing just a partial orchiectomy for these patients. You have to let them know about the uncertainties and the inaccuracies of frozen sections and the potential need of going back to remove the testicle. But this is a new option that's being endorsed by the American Urological Association. One of the other things I've noticed, the new options for patients with seminoma. Seminoma used to be a type of testis cancer where, other than the orchiectomy, there really wasn't much role for surgery. But what we're seeing from now 3 studies for patients with stage 2A who normally would get radiation therapy or chemotherapy, about 70% of those that you do an RPL&D on, or removing the lymph nodes, actually don't have a recurrence in the immediate term. And this may spare them the chemotherapy or radiation that may place them at a higher risk of secondary cancers or cardiac toxicity. Robotic RPL&D is another option that now has just been added to the guidelines for those who are comfortable doing the robotic approach. This is a reasonable alternative to the open surgery. Patients are just in the hospital for about a day, compared to about 3 to 5 days to the open approach, and the lymph node yields appear to be the same. At UNC, we do robotic RPL&Ds, and our intermediate outcomes appear to be fairly comparable to the open approach. And then the last thing I'll just mention is that there's been some also studies looking at the type of scans that we do for testis cancer. This is a randomized control study from the UK that compared CTs versus MRIs and different intensities of imaging. What they found is that there was really no worsening of cancer outcomes when using MRIs into CTs, and the potential benefit here is to avoid the radiation exposure from CTs. But they couldn't say the same for decreasing the intensity of scans. So one thing that we are moving more towards here at UNC is doing more MRIs for surveillance as opposed to CT scans for this population. So with that, I think that brings us to the end. I think I'm running a little bit over, but if there's any time, I'll be happy to take any questions.
All right, Dr. Tan, thank you so much. This has been great. I apologize. I'm going to go back to that last poll everywhere question. And the reason is that's actually a requirement for the pharmacists joining us, that they have 3 questions. So let's just take about 10, 15 seconds. The question was, what is a new treatment option for stage 3 seminoma? And they should have a jump up on that, perhaps, but let's take a few more seconds. And then if you just want to go ahead and confirm the correct answer on that, if you would, please.
Yep, and the answer is RPL&D, which is now an option.
Great. So I'm going to go on to our Q&A section, and that will open this up in just a moment here. There we go. And let me go ahead and turn on my monitoring so that I can look at that. But that will open that up so that we can start to look at questions that the audience has. I'm curious, with our next lecture, our SciSep lecture is actually focused on the lung bus, and that which is a rural screening bus that's going around the state and doing screening specifically for lung cancer. Are you aware of similar efforts or opportunities for urologic cancers? And if so, can you talk about that?
Yeah, no, that's a great question, Tim. So there isn't any screening guidelines for kidney cancer at the current moment. There has been work looking at screening for patients for bladder cancer, specifically patients at high risk, is sort of following the model from lung cancer, where if you identify a high risk population, such as those who are former smokers, and you can combine that with detection of blood in the urine, maybe that's a screening population that's worthwhile. There's actually some data to sort of justify that, but there hasn't been a large scale study to really show a benefit to that. So that's an unproven thing as of right now. And then for prostate cancer, I touched on it before, because of the mix in different recommendations, I think, that's something that hasn't been fully embraced here in North Carolina as of yet, but something we're looking into. There's definitely been a lot of engagement here at UNC with local community organizations, Penn being one of them, Prostate Health Education Network, that's sort of targeted towards Black men, and trying to do more outreach in that group that does appear to be at greater risk.
And that was actually leads well into what my next question was the discrepancies in terms of incidence between Black and white men of prostate cancer and then mortality are striking and alarming. And I know we've known about that for a while. Are there any newer insights into both what causes those discrepancies and ways to rectify that?
Yeah, I mean, I think it's pretty well accepted that social determinants of health, sort of systemic issues, challenges, reduced access, certainly play a role and probably explain a great deal of the disparities that exist between white and Black men. I think, there's been some work looking at the biology of the disease and whether there may be inherent differences between, sort of the two groups. I think the data there has been probably sort of mixed. I think, that's something that's perhaps a little bit less under our control as a health system, but trying to ensure that people across the state are receiving high quality care is within our control and something that we hope to do.
All right, thank you. And it does not look like we have any questions coming in. And I know that we have gone over time, so I certainly understand that and know that our audience and you as well need to get on to other things. So I want to say thank you. Thank you to the University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Center, our team, including Veni Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Lindsay Reich, and Barbara Walsh for all the hard work they put into each and every one of these lectures.